So London classification, what it does, it simply gives it a very simple method on how we should be, classifying our anorectal disorders. So let me start with a basic video on, first of all, how we should be doing it. We all are aware how do we start the machine and set it up for the manometry. If that is clear, I'll directly go on to the actual recordings. Yeah. What? Yeah. Okay. Okay. So after, first of all, we always do a good peer examination. With time, your finger is possibly as good as doing anorectal manometry. Why? Because what are we trying to see in manometry? What are we trying to objectively see? We can actually have a subjective opinion with our peer examination as well. After we had done a good peer examination, we know what do I want to see when I do a PR. I want to look at the tone. I want to look at the squeeze. I want to look at the push, and I also want to look out for any masses in case colonoscopy, sigmoidoscopy has not been done previously. So first thing I would definitely want to see is how is the tone. So like in this patient, I expect a good tone. So as soon as I put my catheter in and I know the tone was nice, I like to see this kind of a image. So where do I place the catheter? As you can see, all the catheters have a high, an area which has a maximum number of sensors or a high density of sensors. That's where my maximum area of interest, whether it is a esophageal manometry or a rectal manometry, should come. So my anal sphincter should come in this particular area where the maximum numbers of sensors are there. That is the first basic thing. Why all these small things are important? Because if we are not doing these small things right, we may not be able to give a correct interpretation when we are analyzing our reports. So you know the basic tone. So if you look into the IAPWG or the London protocol, it tells you once you have placed the catheter, minimum of 60 seconds you should give it to the patient. Sometimes even more than that. But if patient is too anxious, if the patient is a small kid, you wait for a minute, wait for 2 minutes, let things to settle down. Sometimes the tone that you get at the first go may not be the true tone of that particular patient. So wait for a minute, wait for 2 minutes if somebody is too anxious, and once you see on the diagram that the patient is stable, you're getting a good frequencies, then you start your test particularly. Basal tone is very important in lot of cases. What are your referrals when you get for manometry? You get for, of course, for constipation, for dyssynergia. You will get for incontinence. In both this subgroup of patients, the tone is one of the most important things you want to see. If patient has hypotonia and you are dealing with incontinence, you know that you expect the tone to come down, and then you want to go on to the squeeze to see what further information you can get. If you are doing it for constipation, you do know if you have a high tone, first rule out anything locally, and then if you have to work on the biofeedback, you have to relax the patient on the anal sphincter tone itself. So the first thing you have to check is the tone. So this is the kind of graph you will get. If this is a borderline high tone, you can see some rectal slow waves also happening, these straight lines. It could be an anxious patient. Usually in kids, if the kid is too anxious, you can get such line, but that will be throughout. You will not be only in the anal sphincter. They will also be reflected in the rectum. So your whole body is jittery. But if you're getting only in the sphincter, the possibly are slow waves. How do we get them? So yes, why do we get them? So these ones. So why do we get them is patients who have IBS, patients who have even dyssynergia, long-standing constipation, you can get these slow waves. They, in practice, these are the patients who tend to be having more long-standing constipation and somebody who have a more difficult course if you start their biofeedback. That's what I have seen in my subgroup of patients. I think sir may have a different experience in how it, but in my patients, I feel that when I see these waves, I know this patient is going to be a bit tough for me to handle.
So is a slow wave a sign of a pathology or is it a physiological?
It is more of a physiology, but yes, it borders on a pathology because as of now we cannot clearly know whether how much to differentiate in IBS or functional constipation or controls. In a lot of controls you will still be able to see them, but yes, clinically we in when we give them biofeedback, we see that they are the ones who have much worse outcomes.
That yellow that we see with green in the rectum.
So you can see these,
No,
kind
the
of,
top. The top.
no, the top.
Yeah.
This is
We
the rectum.
get, why do we get two different colors in this?
So yeah, so in case there is some stool, there is some amount of extra pressure on one of those area of sensors. Usually you will never find a uniform blue or a green rectum or a uniform blue or a green or the red of anal canal. Somewhere you will have yellow, somewhere you will have green. So possibly some amount of stool, something stuck on the sensor which is giving you that slightly higher pressures. So see, all manometries are very sensitive. So we have to grossly see what is a major abnormality, and sometimes artifacts are very common in all manometries. So we try to lose them out. So once you have set the basal tone and you press on the button as save as the resting period. So once you have pressed this, you have recorded it, and when you go back to analyze, that recording will be there. You can take it for as long as you want. Normally at least a minute is what you should be doing it. After that, as per the protocol, we move on to squeezes. It's pretty simple. You ask the patient to squeeze at a particular time. It doesn't exactly have to correlate where the squeeze is written, but yes, roughly that much duration, around 5 seconds, is important. We do it 3 times. Why 3 times? At least you get a decent number of recordings. It can be 4, it can be 5 if you feel that you are not getting a good value, but as per the protocol, at least 3 values is something you should be doing in every case. Can be more. In case you are doing for incontinence, you can do it more.
Question.
Yes.
The London protocol says that you have to wait for 30 seconds.
Yeah.
Is it that important when it looks so normal?
See, if it's very normal, you can do it back to back. Ideally, yes. Why? Because when you are squeezed once, it will take at least that much amount of time for the tone to go back to normal for the next squeeze to come. Same when you do for esophageal. Why you wait for 30 seconds is because once you've taken a swallow, the next swallow, the intensity, the DCI will be less if you do it too fast. Same here. If you take squeezes too fast, you will not possibly get a truer value. So ideally wait, but if it's something which is very clear or normal, you may do it faster. So 3 squeezes is what we all want, ideally. Cuff. So cuff is very important, particularly the first part of all these London protocol, the squeeze and the cuff, is important for patients who have come to you for evaluation of incontinence. Let me go back to the cuff. Yeah. So how I normally say is that you should have a good cuff reflex if your sacral spinal reflexes are normal. If they are abnormal, you have a spinal problem, you have a cauda equina, these cuff reflexes will be poor. Anything if you have a normal cuff, but the anal canal the reflex is not coming, it may be a higher up spinal injury possible in the same patient. You will have a lot of patients who would come who have road traffic accidents, who have spine injuries. You will have females coming in with obstetric injuries. So there, clinically, how does it differentiate? It tells you whether you are dealing with an urge incontinence or you are dealing with a stress incontinence. Anatomically, it's the sacral reflex arc. But if you have a cuff and patient doesn't have a good anal tone, so that patient will end up having clinically what we as a symptom would be a stress incontinence. So that's where it helps you to clinically correlate what you are seeing with the patient and what you are reflecting here with on the manometry. So make sure you are doing cuff, you are doing good squeeze in all patients whom we are dealing with incontinence. There is, I think I did not show the long squeeze here. Did I not show the long squeeze? Yeah, long squeeze. I think I just skipped the long squeeze. So immediately after the squeeze, you will have this. This is the longer squeeze or the long squeeze. How do you explain to the patient? Okay, you start squeezing and don't relax till I say so. Normally, it will start with the bang, a nice squeeze, and then it will gradually taper it down. They will still be able to, a normal control will still be able to hold, but it will be less in intensity as the starting point. So you have to calculate how much time they can actually hold their initial strength. That if it's around 12 seconds, 10 to 12 seconds, you are still okay. Why? Because what this tells you the urge incontinence. Motion, the patient is feeling that he's going to pass, but he can't reach to the washroom. That's where your long squeeze actually comes in. In patients who have sphincter injuries post hemorrhoidectomy, in patients who had obstetric injuries, urge incontinence may be there, and you will see that the long squeeze is barely there. It's around 1 second or 2 seconds, and they can't hold it. So you will have a long squeeze.
Question.
Yes.
I've recorded a long squeeze or a short squeeze, and I've already clicked it, registered it, and I'm moving to the next thing. But then I realize that I've not really done a good job.
You want to do it again?
Go back.
So you can press on this button here again, and or you can restart the period here.
Okay.
The long squeeze button is here. You can press it again. You will again come back to this particular. You will restart this long squeeze. So you can do it for every step. Whenever you feel that you have not done a good job, you want to repeat it, go back.
No, I've done it, I've recorded it, and let's say I've gone from the short squeeze, I've gone to the long squeeze. Then I realized that it's better do the short squeeze again.
You can again do it, again save it, and you can choose the one which you like. In the final analysis, you will have 1, 2, and 3 options. Whatever you like is the best, you can choose that. After that, our most common area of interest comes is push. So push is something which gives information regarding 2 things. One thing is your rectus push, that is the rectal push or the abdominal muscles contraction leading to a push bearing down effort. Second thing is the anal canal relaxation, or if it's a contraction like in this case, you will also see this. So whereas squeeze is giving you an information only of the sphincter squeezes, a push is giving you 2 sets of information, both of which are clinically useful. If, like in this patient, the rectal push is good, but the anal canal is not relaxing at all, what you have is clear cut anal canal is paradoxically contracting much more or increasing its pressure. So I know when I have to give them biofeedback, my focus would be to try to focus more on anal canal relaxation rather than rectal push. Whereas if I see a patient who has a poor rectal push, poor anal canal relaxation, I have to work on both of them. Why it is important? Because every case of dyssynergia, you go ahead and do biofeedback, every case will be different. It's not a single formula that works for every case. So depending on manometry, what you have to work on with the patient is something you have to do. One extra thing that I do usually whenever I am doing a push is that I put a hand on patient's tummy, and I always want to see whether what I am seeing on the manometry is actually, I am feeling the abdominal push on my hand or not. That also tells me whether or clinically correlates my manometric findings. So that is also important. Your first peer examination and your abdominal feel on how the patient is pushing or bearing down when you are asking him. So
we talk about low, like poor propulsion, poor
Yes.
push or normal push.
Yeah.
What about high, too much of push?
yeah, so pathologically there is no clear abnormality which you say, or no term in, at least in London, to say a pathological hyper pressure in the
Like
push.
you say, during defecation, you should be putting your 5% out of a score of 10. You should not be putting pressure more than 5.
That is straining.
Straight.
That is straining. I'm not usually what happens is patients who have a chronic constipation, when they start with their constipation in their life, even a slight increase in rectal push, they are able to pass motions. Over a period of time, that anal canal or the anal muscles tend to become more contracted. You will need a higher push. Then again, over the years, at some point of time, this balance will change. Whatever you push, you won't be able to relax your anal canal at all, and that's where you ultimately the symptoms of dyssynergia starts to come in. So if you usually these patients, until they are very weak, they are fragile, or their abdominal muscles are not that good, or they are not muscular, they will have a weak push. In every other case, you will have a good strong push, but anal canal is not relaxing, like in this case. So if you have a good rectal push, even if it's high, your focus should not be on decreasing the rectal push. Your focus is to relax the anal canal first. When we talk about that straining thing, that is when we talk about you should not be straining while passing stool. If you're doing it at 10 value, do it around 5 or 6 for right now, but you still have to push. If you are not pushing at all, we are still creating another problem for them. So when you do biofeedback, focus more on anal canal relaxation rather than trying to increase the push or decrease the push. So internal external sphincters anatomically, one is inside, one is out, but you can't really differentiate.
What about the pelvic floor? What is the
No.
pelvic dyssynergia? Is the failure of relaxation of the pelvic floor to correct that angle, making that right angle as a straight angle.
Yeah.
So can you differentiate whether
Not on manometry, but a good PR will tell you whether you are dealing with the whole thing getting descended down or not.
but the pelvic dyssynergia per se deals with the improper pelvic floor muscles or it's improper anal relaxation?
So I have a PPT on actually show. So what it does is it's not only muscles. You have the whole ligaments around that area, you have the muscles, and you have the sphincter. So all these things together will create your pathophysiology. Initially it is the anal canal. Over a period of time, when you have a long standing patients who are exerting, the whole pelvis starts to shift down, and that is when you keep calling it as a descending perineum syndrome or the pelvic dyssynergia. So you will have the vagina, if it's a female, you will have the vaginal ligaments also going down, you will have a prolapse, you will have the levator ani going down, you will have the rectal mucosa prolapse coming down. So it's not only, you can't differentiate on manometry whether this is only the levator ani or only the ligaments or only the sphincter. The initial starting point is the sphincter, but over a period of time, all of these organs tends to become abnormal. And when you start the biofeedback therapy, you will see in 3 or 6 months, all of these abnormalities starts to come back. So if you do an MR at the MR diffico at the onset of your biofeedback, you do it after 6 months or 7 months, you will see that the descent has actually come down. So it's on manometry you can't differentiate, but on an MR you can differentiate if you want to.
What we are checking is that inflating the balloon in the rectum. If we are seeing if there is a direct neuronal connection between the rectum and the anal canal is spoiled, is not there. That's Harshman.
Yeah.
Because there are no ganglionic
Yes,
cells.
yes.
So, how high should the balloon not be before the test is invalid?
Yes. So let me tell you in a very simple way. What does rare reflect, clinical, like physiologically? It's a sampling reflex. So what happens? You have a fluid coming down, touches the internal inner sphincter. Internal sphincter transiently opens, samples. If it has to be passed, external open. So it's a sampling reflex. It's a local reflex. It's not a spinal reflex. So some part of a balloon has to be in contact with your also the internal sphincter. It can't be a balloon hanging up in the rectum, and you are putting a balloon in there and you're trying to see a rare. So that is why I see that sometimes in a mega, not mega, but I should say capacious rectum, you would be able to see. You're not getting rare even if you're putting it. You expect it to be there. You are doing it just for constipation in a very old gentleman, but you still see rare is absent. So gently pull it back. Again, try to see. You sometimes find it.
Does the degree of sedation affect this result?
In kids, it should not. No. I don't. I think it should not. It should not. Not in my opinion. I don't think until somebody is very deeply sedated. But honestly, even whatever level of sedation, rare should be there. that's a local arc, it's an autonomous arc, it should be there. It's not there.
Actually, in deep sedation, your anal tone only goes very low.
That's what I'm
So
saying.
like you
If
said that in
yeah,
hypotonia, it will be difficult to interpret.
definitely, if
So,
you, somebody is in a very deep sedation, yes, you can have a low tone
then
and
you
you
wait
may
for them
find
to
it.
be semi-awake and then
But yes, usually you do kids with the pedicural and so it's not that deep this thing sedation. Okay, so sensitivity testing, I think this like nothing to show in a video. It's like so how do I do that? I asked my assistant to gently. So you can do it by two methods, by ramp method or the intermittent method. Ramp means कि आप 10, you did 10, you did 20, 30, 40, gradually increase the volume. Intermittent is you put in volume first, take it out. Next 40, take it out. Next 60, take it out. I do by the ramp method. 10 ml, 20 ml, 30 ml. You tell the patient clearly three things the patient has to tell you. One, some sensation of something getting inflated, which usually Indian patients will not answer. Second thing, some sensation or one very early sensation of having to or urge to pass stool, that they will start to answer, and then finally maximum urge. Now the problem is I see in Indian patient is when you tell them maximum urge, they will hold on to it like anything. They will hold. I've seen 300, 400 ml, and I don't dare to go beyond that. So and I ask them, do you feeling anything? हाँ sir, जोर से आइए, but you have to speak something up. But they will hold. They will say that we don't have to speak. So just tell them when you have the first urge, and when you say okay, now I have to pass motion. When they say they have to pass the motion, that is usually their around their maximum tolerable levels. Sensitivity, do it at least 3 or 4 times. It's a time consuming thing, but do it 3-4 times in Indian patients. Every time you'll find a different value. So take a mean or whatever, median, average, whatever you want to take, but don't go it by just one value. That will usually be wrong in these patients. And one more thing, one small tip in that, before starting the test, your manometry, check your balloon. I have seen that my balloons have burst and I am putting in air. I reach almost 400 ml and patient says I don't feel anything. So then I realize that my balloon is possibly. So make sure the balloon is fixed. It is properly inflating. It doesn't have any holes. Okay, so that's for and in this you do a gradual inflation, not a rapid inflation. Okay, so in balloon expulsion again, two methods. Left lateral is what I do. It's convenient for me. It's convenient because I don't have to change the position of the patient. 50 ml water, and you ask them to push out. Wait, give them a minute. If they are able to pass out, good enough. The normative that I will say 25 seconds, 24 seconds, anything more than is abnormal. I hold it for a minute. A minute is good enough. If by that time is able to push, I usually don't label it as abnormal, because it takes at least 5-10 minutes for a patient to understand what I'm even trying to tell him to do. So how do you analyze? Analyze is so you end the recording there, you go back to the main menu, you go to the analyze recording part, and this screen will open up. So here you can see so you were asking that we can take multiple recordings. You can choose which one you want to, which recording you want to check, and you can put your markers, begin, end sequence, and you can choose it, and you will see the pressures here.
So in squeeze, we have got 3 recordings. So when I go there and it gives one recording, is it an average of those 3 or is it that particular recording?
So this recording is showing off this value. In the final recording, it will show, in the final analysis, it will show you a mean value. But this is what value you are getting here is this is of this particular recording only. Again, don't just rely on the automated analysis. These values are not very specific for Indian population. It is something, and it's always a range. So I have usually like pressures of 49 being recorded as hypotensive, whereas the average the software says okay, like 51 is the normal. So judge it like clinically, don't, and you can always change it from here. If you feel that the software is not in accordance to the clinical place, press here, go to manual, and you can change your recording. So usually those borderline cases 48, 49 is not something which is very, very low. In India, I think 48 to something is actually normal only. Same goes ahead. So just like you do for the esophageal manometry, you put in all your markers in place. Same way you put all your markers in place for push, for squeeze, and you keep on recording. I think interpretation you all are already aware of. I may not go into what is dysenergia, and that you already are sure you are well read. And that's it for the part of the analysis. Reporting, it will come on that single page. I think I don't have the image of the recording of the reporting. So I'll just tell you. I think you may have you seen the screen on the London classification that comes reporting. So on the left hand side you have the descriptive findings. On the right hand side you will have the recordings in place. If everything is straightforward, you can go for the automated analysis. It is usually right. You can use that, and you always write something in your medical comments, like in your comments area. What you feel is the abnormality, and what you feel is that the referring doctor should work at. For example, if the rectal push is poor, or you mention it that patient needs a biofeedback therapy, possibly working on the abdominal muscles. If on a peer examination you felt that the whole pelvic thing is coming down, you please refer them for a pelvic floor muscle therapy. It is adjunct to biofeedback therapy. It is not the same thing. It is a set of exercises which somebody has to do. I'll show you some slides on those also. And there are other, to give a nice detailed report on when you do your manometry, whether it is esophageal, rectal, colonic, or whatever you do, give a descriptive report of what is your clinical judgment of that patient. Okay. Anything else in here, please? It's not physiological. So 20% of controls will not be able to pass even in squatting position. In left lateral, you can, in my practice, around 30%, 40% are not able to pass. I use a gentle tug on the catheter. If they are still not able to pass in 1 minute, and the other parameters are in accordance, like they do have on a push they are showing dysenergia, that will be abnormal. If patient has anal canal relaxation while I am doing push, and the only abnormality is abnormal expulsion, so your reporting will be abnormal expulsion with normal recto-anal coordination. So that is a indeterminate abnormality as per the London. So that usually means that the patient is okay. You don't need to worry that much. So even in the London algorithm, you see it comes under indeterminate. It's not a major. In fact, even abnormal expulsion with recto-anal dysenergia is also in minor. So that's the problem I have with all the Chicago and the London thing, is that divide into major and minor. That's what the original description. When you tell a patient it's a minor thing, whereas he is the one who traveled 1,000 kilometers to get that test done. So it's good for us clinically. Okay, we are not dealing with a major medical illness, but for the patient, it's not a good nomenclature to give in a report. So usually I don't write major, minor. I just write what are the descriptive findings. You gentle tug, not very hard pull, just enough to, when we put in a stent on ERCP, we just keep a wire traction. The word is traction. Just a gentle traction, and that is enough usually.
So, when you are doing the London classification, if the patient is in a position to expel the balloon,
Yeah.
the actual manometry doesn't really matter.
Yeah.
So, if a patient comes for anorectal analysis, why don't we just do the balloon expulsion with a simple device first? And if you can expel the balloon, don't stick him on to
So as I said, you don't have to do all the steps in a
Why
revision.
is it not
Don't you think you need first to answer it?
don't I need to?
He's just saying balloon is normally abnormal.
So, ma'am,
but आपको
yeah.
importance of push भी तो बता रहे हैं.
I have something. There was a good study, I think, I forget the name. It came in Neurogastroenterology or something. They compared OPD based balloon expulsion test in an OPD with a normal, easily made equipment versus a manometry. So, just to diagnose dyssynergia, both are equally good. In fact, what I am telling you is even doing a PR is good enough in my OPD to tell that this patient has dyssynergia. What it does not tell you is what to work on. If you have to work out of two components, which is the weaker one? So, if patient is able to pass a balloon expulsion in the OPD or do a good on a PR is like pushing my finger out, is fine. You don't need to push him for a ARM. But usually it's pretty clear. History is clear. You do a PR, you feel that patient is not able to push. You do a manometry and objectively define it. But yeah, you're right. If the patient is able to pass a balloon in OPD, you may not ask him to do a whole test. Anything else? Yeah, please. Dyssynergia versus. So both are different entities. If you like, it depends on what clinical the graph, the video you mean.
So how you work on the biofeedback when you get this abnormal balloon and abnormal push?
Yes, I think the second part I will just cover quickly. Do we have some more minutes?
Yes, yes.
Can I cover the biofeedback also? I think that will answer your question also, ma'am, and that will answer your question also. So I'll skip the indications. You all know what are the indications of biofeedback and what are the goals of biofeedback. So Dr. Rao originally, gave the original articles on biofeedback therapy. He gave into three phases. The first is the patient evaluation phase, then you have the active phase, and then you have the maintenance or the reinforcement phase. What we usually talk about sessions is the active phase or the in-between one. The patient evaluation and education usually we had already done in our OPD settings when we are doing manometry. That part is usually over, but yes, it's something which we have to reinforce when we are doing each and every session. So when I read all of that, I made this protocol. This may not be a very correct protocol for everybody, but it's what it works for me in my practice. I went through all the articles and what it works for me. So first of all, I tell the patient what is biofeedback and what we are going to do on a biofeedback, how biofeedback is going to help you. If your patient is educated enough, he will understand the whole logic behind it and what to do. In my first session, I just sit with my patient, I wait, I give him half an hour, 1 hour, and I just talk to him. Where is he from? What does he do? What is his work? How is his family life? What are the stressors in his life? What kind of food does he eat? Vegetarian, non-vegetarian, what in vegetarian? So I can identify whether I need to change something. As I said in the first line that all biofeedback protocols is not one size fits all. You have to kind of personalize it to that particular patient. So you need to have information regarding everything before you personalize it. So first session is usually that. We talked about the straining 10 value we can do to 5 and 7. Time toilet training, I think in the morning also we learned that we can ask them to, when they get up in the morning, if they don't have an urge, ask them to have a water or eat something and then try to pass. So time toilet training is something which is useful. You obviously have to prevent stool impaction and you have to ask them not to use any like fingering or anything to get the stool out or the jet to stool out. So then you actually start the true session. I'll show you the video also in the end of how it looks on the screen in the software itself. So I do it in the left lateral position. More physiological is obviously the commode. It's difficult to pass the catheter, and then you can have a customized commode where you don't have where it becomes easy to kind of put in. But in a daily practice, it's easier for both the kind of patient as well as for you to do it in the left lateral position. That's what I do. Two screens. If patient is lying like this, I am here, my screen is on this side, and patient is facing the screen on that wall. So that is very easy for him to see, and if possible a large screen for him to read whatever is coming and to hear whatever is coming. Correct. You tell them regarding the posture. Obviously, you have to explain to them. First step is diaphragmatic breathing. You all know what is diaphragmatic breathing. One hand chest, one hand tummy. Inhale, the hand on the tummy goes up. You do it for a few times, twice a day, if possible after meals. Then first few sessions is squeeze and relax. I'll show you the video. So you focus on the anal sphincter first. You ask them to squeeze, and then you ask them to relax as much as possible, and do it whatever 30 times, 40 times, whatever time it is possible during your session, and ask them to do that again and again at their home also whenever they get time. Even if the office they are sitting, they are not doing anything, on the chair, squeeze, relax, good enough, whatever it works. So you have to make sure your patient has learned these two techniques well: abdominal breathing, or the diaphragmatic breathing, and the squeeze relax well, because once they have mastered these two things, which will take 3 or 4 sessions, only then you can go proceed ahead to try to coordinate these things together, and then you train them on a push technique. You can't just not have them learn diaphragmatic breathing and just start them on a push training. So session 2 is again the same thing. Because in one session they will not learn the correct posture, you will again have to reinforce it in next session. So it takes 3-4 to learn that. Usually by session 3 or 4 I add the simulated defecation, is what I said. Once they have mastered those first 2 steps, then I ask them to combine them together. You relax and you push, you relax and you push. So that's when they start doing. And after they are done on 6-7 sessions, I give them a Foley's catheter. I cut the upper end. On the balloon, I put in the 7.5 size glove thumb, and I tie it with a simple suture, and I give them to them for their home. It's very cheap, $100, not more than that. And they go home and they use that thumb, which is a stool shaped, sausage shaped thing, and they go home and they practice on that Foley's catheter with they inflate the balloon, they do it, they insert, and they will try to push it out. So this is usually by session 5 or session 6 is where I give them. After that, I am sure they done well on the machine. So that is where. So after completion of this phase 3, when they have done well, I give them that Foley's with the glove. So 4 weekly sessions plus home plan. Session 1 evaluation. This I already told you, so I think no point. And then this photos are from Dr. Shivani. I think she was doing it for a patient, and I asked her to give me these photographs. So these are some of the exercises which you can ask them to do. This is from an article, I think from Indian Dr. Mayank's article only, on how adults can do a pelvic floor exercise. This all is good to know as a gastroenterologist, but you still have to refer them to your physiotherapist until if you have time, you can of course do it yourself. So let me show you these videos. Okay. Squeeze training video. Okay, so when you begin, you will have this kind of a image. You can choose which you want to do. In the first course, start with the squeeze training first. You will have this kind of a image on your screens. You have the anal pressures here. You have your live recording here. One diagram to tell the patient the basic anatomy. You can choose the anal canal, you can define the anal canal from this area, so the pressures are automatically chosen. You can either manually track, or you can ask the software to auto track the pressures. This 2 points are usually for the feedback. Either you give a visual feedback by looking at the screen, or you give an auditory feedback, you tell them and they will learn it. And finally, these are the pressures which are there. 120. So this is the maximum. This is the minimum, and this is where you don't want it to come too low. So when you are starting with the squeeze, I usually what I see on my rectal manometry, what are the pressures, like what are the squeeze pressures on the manometry. If they are around, let's say 180, and I set the pressure to 120, it will not be of any use to that patient. So I will increase them to almost 200, 220, 240. So then then they will have to learn to squeeze hard and relax. I want to fatigue those muscles during my first few sessions. So this pressure I usually keep it higher than what they have achieved during their manometry itself. I'll show you here. So see, I have increased it to 200 to almost 250 now, the anal canal pressures. So this patient's baseline was 120, and when they squeeze it goes up to almost 200. So I kept it around 250. So when they are squeezing, they are really making an effort to squeeze, and then I asked them to completely relax down and bring it down to less than 100 if it is possible. I asked them to focus more on their relaxation than the squeeze itself. In the beginning, you will see it's actually, in the beginning, you will think it is counterproductive. They will ask them to squeeze much, but over a period of the session, towards the end, they will start to exhaust those muscles, and you will see they are relaxing more than what they were in the beginning of the session. So you keep doing it 3, 4, 5 times, they will tend to relax their sphincters well. I think this is the squeeze. So first couple of sessions, only this much is actually what you want to focus on, plus the reinforcement of what you have already done in the first session. Then I think last part would be our push training. Yeah. So this is the push. So you have the rectal pressures now, you have the anal canal pressures now, something similar, you have a live recording. Here you ask the patient to exert. She will start now. Yeah, she will start exerting now. This is after, I think, this is the 5th session or a 4th session of this particular patient. So you can see anal canal has now started to relax a bit. This is the same one I showed you the manometry of originally. The first recording that I showed you, you saw he had dyssynergia. So he went for biofeedback, and now around 5th session he is able to have a good rectal push, and he is able to relax his canal well while he is pushing it down. So as you can see here, the canal is relaxing well at this point when he is pushing. So this is somewhere around 5th or 6th. So at this point, when I do a BET, if he is able to pass in 30 seconds or 40 seconds, then I will give him that Foley's and a glove, and I say, okay, now you can be at home. I will call him back after 3 months. Usually by 3 months I see them that this bad habit again tends to creep in. They will again go back to their original problems. So at 3 months I call them back. I again do couple of sessions with them, and I reinforce what they are doing here, and then they are usually okay. So that's it's a bit boring job. It's a time intensive job. You need to have time out of your interventional endoscopy to spend on this. So any questions on biofeed? This is just what to explain to the patient what we are doing. Any doubts or anything?
Like you said,
What's your success in biofeedback?
Sir, very good question, sir. What I feel is that kids do very well, young adults do okay, elderlies above 50, 60, somewhere where we struggle, not, I think sir may have a better value, I am around 40, 50%, not more than that. I think your,
50% is
Yeah.
I know studies show 70-80%, but it's really case specific.
The rest, yeah.
So I think a lot of patients just drop out. They don't
Most of them drop
continue
out,
it.
yeah.
If I started off with 10 biofeedbacks, maybe 4 or 5 only will continue. The ones who continue are the ones who do well. Why do kids do well? In fact, actually, if you see the pediatric guidelines, it's written in ISPEGAN guidelines, it is contraindicated. So initially I used to do, I've done a few kids initially, and then honestly I had not read the guidelines till quite late. And after I read that, I took a step back because if somebody questions you.
No, actually, just to add on, the guidelines that, as
Yeah,
far as
yeah.
my knowledge goes, the guidelines were last made in 2014-15.
Yeah, I know that.
They were made in 2014-15, and that time the consensus was because there was no differentiation between dyssynergy and functional constipation. So they said that for functional constipation, they don't have the evidence to say that biofeedback works. They need more studies. So last 5 years, there has been encouraging data on biofeedback therapy in children, and especially because manometry has come up, so we can differentiate the dyssynergia group versus the other group, and we know that it works in dyssynergy.
So for
So now they are coming, and I think they learn really well.
Yeah, they learn fast.
He was telling them that high squeeze and then relaxation. One patient day before only called me. The mother said the child is asking that ma'am tells me all the time to relax on the pod and relax. But she's always telling me to first squeeze and then relax. So they noted so well that they learn it so well.
So I have two theories now. These are theory why kids or young adults do well. One thing is that they learn it very quickly and learn it very well, as compared to elderly who may have more fixed thoughts on what to deal with. Second, I believe that if you have constipation or dyssynergia for 30-40 years, the structural changes that take place over a period of time are much harder to treat and reverse as compared to comparatively a younger person where possibly those structural changes are not in. So I have few patients who have dyssynergia. The problem in them was that it's been so long standing, and they are doing finger evacuation, they are putting in jet, they lost their anal tone. So whereas we expect them to have a tight anal tone, and they actually have no tone left, but all they have is a rectal prolapsing down. So those are the hardest ones. They are the ones you actually have to refer them for a star or a gracilis interposition. So when you have that much structural change, you can't really treat them with biofeedback. I have a friend he's in Surat. He says he had done a few such cases. His results are quite encouraging. But in my opinion, they will require possibly 20-30 sessions to reach that level. But that much I am not sure my patients will spend or earn.
The only thing I do differently with the children is I give them a longer trial of the osmotic laxative before I start the biofeedback. So normally in adults, your threshold is very quick.
Very quick.
But in a child, I would sometimes tell the parent that this is something we can do.